Hello my lovely friends, I am Dr. Arun Swami, your physiology faculty. In this video, we will discuss about the NMJ neuromuscular junction, as the word is telling that neurons and the muscle junction, and we know this junction is required for the muscle contraction. Now, whenever we'll talk about the motor neuron, they are the neurons which carry signal from the brain up to the muscle. And this motor neuron is having a different areas. The area which taking the signal out from this neuron we call as a axon. And axon where it ends we call as a terminal axon. This axon is the longest part of the neuron and it contained the myelin sheet over here. This myelin sheet provides the faster conduction, faster signaling. Whenever this axon terminal area ends on the muscle, this is making a junction we called as NMJ. So how this area is actually looks like, we are going to see. Guys, this is how this area is actually looks like. So you can see the above area is the presynaptic area and this muscle area we called as a postsynaptic area. So let's discuss about this neuromuscular junction. Now, the definition, the neuromuscular junction is a chemical synapse which is releasing the different type of neurotransmitter between the alpha motor neuron and the skeletal muscle fiber, where nerve impulse are converted into the muscle contraction. Guys, please pay attention. Very important. The first thing that is this is a chemical synapse, and the chemical which is releasing from this neuromuscular junction, this is your acetylcholine. Now guys, how this neuromuscular junction is actually looks like, please pay attention over here. As you can see, this is the terminal axon area. Now this terminal axon area, it is ends over here, it is joining with the muscle area, and guys, how this area release the chemical, it reach into this area, and so that this area gets excited. Please pay attention. There are certain steps to functioning of this neuromuscular junction, which is repeatedly asked MCQs in various examination, in MBBS final examination, in NEET PG or in FMG examination. So guys, please pay attention. What is the step-by-step sequence for functioning of this neuromuscular junction? So the first thing is that, first of all, the action potential comes from the above side. The action potential, which is a type of a current, it is coming from this axon part. It is coming from the upper side to downside. So the first step that the action potential comes and reach at the terminal axon. This terminal axon contains the special calcium channels over here. These calcium channels are actually sensitive for the action potential, and whenever this action potential comes into this area, these calcium channels are going to be open. If this calcium channel is opening due to the current, guys, these channels we call as a voltage gated calcium channel. There are two type of voltage gated calcium channels are there. That is number one is fast calcium channel and another one is slow calcium channel. So two type of calcium channel is there, fast and slow. Please pay attention. Whenever the action potential coming up, it leads to opening of this both calcium channel. Once the calcium channel will be open, the calcium start going from outside to inside. We call it as a calcium influx. You can see over here, there are a bag-like structure. This containing a chemical inside of it we call as a acetylcholine. Guys, these bags are actually we called as secretory vesicle. What we call this? Secretory vesicle. These secretory vesicle containing the acetylcholine. So whenever this calcium gets entry inside of it due to the action potential, guys, these secretory vesicle, they are attached via a special chemical over here or via a special protein over here, and this protein we called as a snare protein. What we call this? This we called as a snare protein. Now please pay attention. This snare protein is a very important part. Once this calcium enters into this terminal axon, this snare protein gets activated and this vesicle going to be attached to this cell membrane area. Once this cell membrane area, this vesicle is going to be attached, this cell membrane going to be break and all the chemical release into this synapse. Guys, please pay attention, the space between this pre and the postsynaptic area, this space we call as synaptic cleft, and all this chemical will enter into the synaptic cleft. This synaptic cleft, after that, this chemical will reach into the postsynaptic area. And in the postsynaptic area, guys, there are the special receptor present over here for this acetylcholine. These special receptor, they binds with the acetylcholine, they send the message for the nucleus, and nucleus opens the sodium channel. Once the sodium channel will be open up, the sodium start moving inside, this we call as a sodium influx, and leading to positivity inside of this muscle area, we call as a postsynaptic potential, right guys, excitatory postsynaptic potential. So you can see over here, what are the steps? Number one, the action potential is coming up. So this is the nerve impulse. Second part, calcium channel is going to be open. So calcium influx. Third thing, snare protein activation and leading to vesicle release into the synaptic cleft, we call as exocytosis. So this is the exocytosis part. And then number four, it binds with this receptor, and after that, opening of the sodium channel. So you can see the fourth step is binding with the receptor, fifth step is opening of the receptor or opening of the channel for the sodium and leading to postsynaptic potential, and ultimately nerve impulse will be start. It will go into the DHPR, it will activate the ryanodine receptor, calcium will move out from the sarcoplasmic endoplasmic reticulum, and it will go to the troponin C, tropomyosin will be removed, and actin-myosin coupling will be happen. So this is how this neuromuscular junction is actually functions. Most of the exam, they used to ask the step-by-step approach, what is the proper sequence, what is the true, what is the accept, such type of question may ask in your various examination. So guys, please remember all this step-by-step functioning of this neuromuscular junction. Please pay attention. What are the different pathological conditions? The number one condition, if this fast calcium channel gets mutated or they gets defected, guys, this condition we called as Lambert-Eaton syndrome. What we call this? Lambert-Eaton syndrome. And you can see this Lambert-Eaton syndrome is happening at this area. This is the presynaptic area. So Lambert-Eaton syndrome is a presynaptic condition. Now the next part is, if this snare protein gets deactivated, guys, this is damage via the botulism toxin. This is damage via the botulism toxin. Hence, no exocytosis, no muscle contraction will be there, and that's why the Botox injection lead to the muscle relaxation. This is also the presynaptic condition. Number next, if suppose these receptor get damaged, guys, this condition we called as myasthenia gravis. What we call this? We call this is your myasthenia gravis. So you can see the myasthenia gravis is a postsynaptic condition. So one more time, this is Lambert-Eaton, this is botulism toxin condition, and this is your myasthenia gravis. These both two are presynaptic condition, and this is your postsynaptic condition, right guys? So this is the different pathological condition. So you can see the structural components are presynaptic terminal, that is the nerve end, contain the acetylcholine filled vesicle, voltage gated calcium channels are there. Then the space between the pre and the postsynaptic area we call as a synaptic cleft, width is 20 to 30 nanometer. It contains the acetylcholine esterase. Guys, whenever the age is there in the end, it means this is a chemical which can break to the acetylcholine. So guys, whenever the acetylcholine release into the synaptic cleft, the unutilized acetylcholine need to get off from this area, and this breaking is done by the acetylcholine esterase. Now, the postsynaptic membrane, this is motor end plate containing the receptor for nicotinic area. This is called as NM receptors, nicotinic muscular receptor. And there is the increase the junctional force to increase the surface area. So I told you, whenever there is a mucosal folds are there, it increase the surface area, and sodium channels at the base of the folds. Talking about the sequence of the event, so we already discussed nerve action potential will reach at the presynaptic terminal, calcium will be influx, vesicle fusion and acetylcholine release. Acetylcholine binds with the NM receptor and plate potential generation and muscle action potential leading to sarcomere contraction, and the extra acetylcholine will be degraded via acetylcholine storage. Talking about the different pathological condition, myasthenia gravis, this is when the receptor levels are decreased, and this is the autoimmune condition. Features: muscles cannot be contract, so drooping of the eyelid, like ptosis, diplomia, proximal muscle weakness. Weakness increase with activity, and guys, is one special feature. Myasthenia gravis, the morning condition and evening condition will be differ. Morning of myasthenia gravis will be better in compared to the morning, evening will be worst. Please pay attention, very important part, right? Very important part. And the treatment is acetylcholine esterase inhibitor. And who's the inhibitor? Neostigmine and pyridostigmine. Lambert-Eaton syndrome. This Lambert-Eaton syndrome, it is again autoantibodies against the presynaptic calcium channel. This associated with small cell lung carcinoma and features proximal muscle weakness, improve with the repeated use. And remember guys, here the morning and evening condition. In myasthenia gravis, the morning was better, evening was worst, but here it will be reverse. In Lambert-Eaton, the morning was worst and evening is better, as the line is saying, improve with the repeated use. Improve with the repeated use. The next part is your botulinum toxin. In botulinum toxin, as I told you, it blocks the acetylcholine release and it causes the flaccid paralysis, and it used in the dystonia, blepharospasm and the spasticity. So some quick points to be remembered. NMJ receptor, this containing NM type of receptor, nicotinic neuromuscular receptor. The myasthenia gravis is postsynaptic defect, Lambert-Eaton is presynaptic defect, and the botulinum toxin is decreased acetylcholine release. So I hope now all of you can easily remember about this neuromuscular junction. Thank you for watching this video. Thank you very much.